I think one of the things we've heard is that the tendrils and tentacles of this issue go very wide. And so I'm going to give them a lot of latitude. So let me just introduce them, starting from this end. So we have Dr. Barbara Silverstein, who we saw earlier. We have Pamela Mancuso, who's Vice President, Region 1, Ontario Nurses Association. So welcome. A new panelist as well is Dr. Sandra Mackay, Manager, Research and Evaluation, VHA Home Healthcare. We have Henrietta Van Hull, who we've seen before. That sounds bad, doesn't it? From PSHSA. And last but not least, Dr. Mike Frey, who we saw this morning. And so the mandate that we've given our panelists is to say we've heard a little bit about the challenges, we've heard a little bit about research and what it can contribute, and we've had a number of presentations that range from training, through equipment, through larger issues of work systems and facilities. And so the purpose of the next section is to say, for the panelists, is to reflect on the day and see how what we've heard meshes with their experiences and their knowledge. And I gave them a number of challenges.
Yeah, I sure did.
And this is one of them that
we can't see.
Over the day and over what we've heard, we've got issues in both hospital, long-term care, and community care. Up in the right-hand corner, we've heard about work systems, policies and procedures, equipment and training. But in terms of action, I've also asked them to think, well, who might do what? Because the tendrils, as I say, reach exceptionally far, and not everyone can do everything, and there probably needs to be action at many, many levels. And so this figure here is schematic. And when I say schematic, I mean the words don't have to be in that place. And so that was something I put together, and so this is definitely arguable, but the point I wanted to make with the figure was that as we go outwards through here, everybody has different powers, has different knowledge, different requirements, and in order to help reduce MSDs in healthcare, there probably needs to be action at many, many levels.
We can't see your figure.
Oh, this is a secret there. This is interesting. I made this up just before the panel, so that's why. So, for the benefit of the panel, at the bottom of the slide, it talks about the patient, the client, and the family. Moving up to caregiver, then supervisor, manager, then individual employer, and I've put in ergonomists there as a plug for ergonomics as a piece of the solution. Then we have labor, health and safety, sectoral associations, and at the top, or on the outside, depending how you view it, ministries and government. And so those different players, those different people who have an influence on the way that lifting, transferring, and positioning actually happen, and how each of them contributes to that. And so the thinking is, and the panel probably has different ideas, is how, from what we've heard, can we not only reflect on what we've heard, but also where we might go from here. And hopefully if we leave, we've got some idea of what the different levels of action might need to be. So, without any more preamble, I'd ask if any of the panel wants to chip in on their reflections of the day, perhaps, to start.
I think that was mine. It's very loud. Are we staying with your slide, Richard? All right.
No, we're not.
Oh. I think what's been really a key thought for me is that we've had an opportunity today to start off the day looking at these potential barriers and the blockages and the things which hinder our ability to deliver a safe place of work. But during the practical case studies here, we've seen that actually there's some really strong evidence that goes, although some of the science is missing in a lot of the measurement of outcomes, and in particularly this real challenge of reducing musculoskeletal sickness, absence, time, and time lost. That there are lots of improvements and lots of really strong packages that are starting to show that that level of evidence. So, in a slightly different format, I'd interpreted the list of role players within this process when I was just trying to put together an opening slide here. That actually but it does fit. If you imagine that the pink is the list at the centre of the segmental diagram that Richard put up, and then in the blue and the purple we've got these external processes. So our pink is our organisation, and what we've been able to see in the case studies today is that if you create change and process and policy and education and supervision and monitoring all the way across your organisation, you stand a much better chance of having some sort of success. So part of that is about the patient and the interaction with the carer, the interaction with the physical environment, but it's also about, and we've identified through some of the sessions here about these other roles within our organisation, looking at supervisors, looking at whether or not you encourage peer support workers or peer review, whether you look at champions within your organisation, whether you look at trainers, and there are various interactions and various systems that the different people have identified, but that creating a culture, creating a positive way forward with trying to deliver your wide organisational intervention, appears to be one of those things that have come forward out of the presentations from today. And I was reminded of something that a health and safety colleague informed me of many years ago, and that is and something that which still stands up today, and that is the KISS principle. Yeah, keep it simple, stupid. Because one of the real difficulties that I think many organisations have had is that healthcare, community care, acute care, within a governmental-based organisation where you have 5,000, 8,000, 10,000 people working in your system, that you might have 100,000 visitations from patients a year, that is a complex process. So it's complex by its delivery. If you then create a really complex set of solutions, you have no chance. So you've got 10,000 people looking at your work situations from a different angle because of where they work and what they do and what their role is, and then you create a really complex solution for them. It's not going to work. My mind is taken back. I went to a management of aggression program, which was interesting. I could fend them off with a yogurt pot, a knife. They were pulling my hair, grabbing my clothes. I got to the end of the week and I could barely remember my own name. I went back to the trainers and I said, do you know how complicated your program is? They said, what do you mean, Mike? We've been doing this for 10 years. I said, I've worked it out. There's 127 scenarios. How is that meant to work? How is that, a really complex process work? So I think simplicity is key. I think having the same approach and the same method all the way through your organisational, all the way through your pink structures here is an absolute an absolute must in terms of getting buy-in, getting compliance, getting agreement, getting people to agree with that with that process. But we also have to work in an environment and in a situation where we have external influence. And health and all of the different delivery processes of health are about that structure. There are financial people from government chasing the delivery. There are people from the departments of health chasing your delivery. There are people from the labour organisations chasing your sickness absence data. And so there are a lot of external influences that, that sit within that process and sit within that structure. So we do have to bear a lot of those processes in mind. And I thought before I try to encourage the other people on the panel to offer their input, I was also minded of one particular question, and I think this would be an interesting question for those of you who are challenged by provision of community care with the question, and that question is, in your organisation, and very specifically in your health and safety legislation and guidance, where does I wrote my question down somewhere. Oh, there it is. And that question is, where does the responsibility lie for the delivery of safe work? Because I fully understand the financial challenges, but there is a question about allowing people in your organisation to do unsafe work. Now, it is a massive challenge, and I don't expect us to be able to answer that question now. But this is something that lots of organisations and lots of health providers have had to deal with. They have to go through that process of saying, do you know, enough is enough. There has to be a method, there has to be a process that says this has to stop. And internationally, people talk about the process of risk assessment. And risk assessment is identify the hazard, evaluate the risks, and control the risks. It is not a risk assessment. The process is not complete unless you have controlled it. And that's one of the challenges that we have. And financially, that's really difficult to be able to achieve. But at the end of the day, if we don't manage it, we're just accepting it, which is a very difficult place to be. To go to say, well, I know it's going to hurt them, but we'll just let them do it. So it was, having listened to the real challenges and complications in the process in that first session today, it was something that it felt like that was part of the. Part of the questions, part of the process that you have health and safety legislation. One or two people said, if we do not do this, we are negligent against our duty. And it is an interesting process that, that the organisation, your organisations and many organisations before that point have had to deal with. So there are lots of people who have a part to play in this management of risk, creation of safe systems, maintenance of safe systems. So does anybody else want to join in?
You can go next, and then I'll go after you.
Do you want me to? Okay, sure. Is this on? Yes. Okay. So I can say whatever I want, but it won't be with an accent, so it's never going to sound as good as what Dr. Frey said. So I think the important piece is that we have had a lot of maybe anecdotal evidence that we really need a comprehensive program if we're going to deal with the issue of client handling. I think other people have said it, training alone does not affect change. You have to have all the pieces in place. I don't think it matters exactly what program it is, whether you've purchased one, whether you have the internal resources to build a SPLAT program, or whether you use CBI, who trains our Handle with Care program. I think the important piece is that the pieces are in place and you make it work within your own organization and within your own culture. So anyone who has a program and wants to go through a comprehensive checklist, email me, I'll send you one, and you can take a look and see how your program matches up to what's considered some of the best practices. I'm happy to do that. I think one of the roles of the health and safety associations in Ontario is to not only to assist you, but to also advocate for healthcare overall. I think it's important that all of the ministries, including the Ministry of Labor and the Ministry of Health, understand and know that healthcare is unique, that the challenges that are faced by healthcare workers are different than that of almost any industry. There's lots of safety professionals in this room, and there is a hierarchy of control that we preach and we live by. However, it is very difficult to engineer the patient out of your workforce. So we do have to still acknowledge that there are some things that we do have to work around within the healthcare sector. I do believe, I think it was Dr. Frey who said earlier, that this is you can't take the patient safety piece out of this, that we have to make this also a quality of care issue. And I think that helps us when we're building a program, and it helps us to get buy-in not only from our own staff, but from the ministry and so forth. One of the other things that we are doing as a safety association, just so you're aware, is working with 7 other provinces that also have a healthcare safety association, and we're sending a letter of request to Accreditation Canada to expand all of the patient safety things that are in Accreditation Canada and the leadership and governance standards to include a more holistic approach to safety. So it's not just about patient safety, it is about overall safety. So we are not maintaining these silos where risk management is only about patient and the public, and occupational health and safety is only about the patient, or only about the staff. We should be working together, and if we had indicators and quality standards that led us to that, it would save a lot of, and I've been an OC health nurse, banging your head against the wall for dollars and support for the occupational health and safety program in hospitals. And I think one thing that Dr. Frey just said was about the KISS principle. There are certain minimum standards that we should have in any program. This is the key principles, but if you want buy-in and you want staff to follow the program, you also have to build in a certain autonomy for them to be able to make some decisions. So these are the key pieces, but within the program, sometimes we need to do our own individual risk assessment and make sure the program fits within the type of work that they are doing in that department, in that unit, in that healthcare setting, whether it be home, long-term care, or acute care. And I think that's probably enough for me.
That's great. I'm going to talk a little bit about the union perspective involved in all of this, because of course I am from the Ontario Nurses and I'm one of their vice presidents, so of course I think and breathe union. But unions can do a lot in regards to patient handling, health and safety issues, etc. And I think that unions have to take a proactive role and work with their employers and have that communication and dialogue so that they can ensure that people are safe and patients are safe and their staff are safe. And I think that that's one thing that the unions can do. They can ensure that the Joint Health and Safety Committee is active and vibrant and ensuring that the dialogue is occurring. As I said, as was said earlier today, our CEO sits at that table. We are able to make decisions right away when it comes to the health and safety of our members and any clients that, if they bring their issues forward, we try to address that as well. But I do believe that Henrietta has hit on a key point, that we need to have more dialogue and communication at all the levels and not be working in silos. Another thing is unions lobby the government. We sit on government groups. The Ontario Nurses is sitting on the sitting at the violence table as well. We have legislative changes that have occurred because of our lobbying, which was Bill 168 after the death of our nurse that was murdered in the workplace. So there's lots of things that the unions can lobby for in regards to change. And again, having the dialogue with our members at the floor level all the way up and ensuring that that's occurring so that you can work together, because this is all about working together. We know the dollars are slim at best. We know that everybody's competing for those dollars, but when you can create a safety culture, it does affect change. And I think that I've seen it in my 30 plus years as a nurse. I remember having a workplace that didn't give a damn to a workplace now that looks at everything that we do and really does try to put that promise in there that they'll look after our well-being. So I know that change can take effect. Nurses have this Florence Nightingale syndrome. We think that it's part of the job to be injured. We do. If patients are falling, we'll throw ourselves under them to save the patient. It's been a tough go to tell a nurse to let the patient fall. And I'll tell you, I got a lot of feedback from nurses about letting the patient fall, as far as even what kind of nurse are you? And I said, but what kind of nurse are you when you're injured and can't work and look after these patients? So it is a shift in mind and culture for nurses, for sure. And nurses, to be quite honest, a lot of seasoned nurses like myself, we didn't have lifts when I started. We did everything manually. It's a lot faster to move a patient in a bed manually than it is to bring a lift in. But guess what? A lot of our nurses are injured now. So I think that education, training, all those key components are certainly needed, but we also have to have that loop that ensures that the training education is actually not only delivered, but complied with. And again, unions can work with the members to make sure they are. It isn't top heavy. You should be working together, because at the end of the day, we all want to go home. We don't want to have a back injury. We don't want to have a patient have a serious injury because we aren't doing our jobs. So I think that's one thing that unions certainly could be involved with at the labor end. And of course, Henriette has talked about health and safety organizations that are involved, along with a lot of the development of programs and best practice. So we need to all work together is the bottom line.
Well, I might have said this. Is this on? Yes, it is. Oh, you have to get right next to it. I might have mentioned this earlier, but when I was working as a nurse at Detroit General Hospital, this was a long, long time ago, and 3 of us were lifting a 350-pound patient out of the bed into the wheelchair, and the other 2 let go. And so I ended up underneath that patient and went through rehab for about 6 months, and really had never felt like I could never work as a nurse in a hospital again. And that story is told again and again with like huge numbers of nursing staff across the US anyway, and Canada, I imagine, as well. And then the question then for me became, okay, so why did this happen? I mean, what is it? And I talked earlier this morning about really using a systems approach to see where there are breaks in that system between the technology that's available, the way work is organized, the kinds of tasks that are performed, and the patient, or the worker in this case. And I think that a systems approach is really the only way that we can like look at an organization, like a hospital or a nursing home, or home health care, as I said earlier, I think that's the wave of the future, and we're, at least in the US, in deep trouble in that arena. But I think using that kind of approach, we can come up with solutions. And I think it's really important that we begin to share those solutions and the basis for why we believe those solutions really are solutions, and sharing that across the entire community, both in Canada and the US and wherever else. So I think that that's really one of the most important things. Safe patient handling committees in hospitals are really important. And but they won't work without having management support and management involvement, not just, oh, yes, I support this, but that they're actually involved and that they make available the funds that are necessary to be able to have ongoing implementation and evaluation. So those are my notions. We really need to have a way of developing and sustaining these programs because they come and go. They absolutely come and go with management turnover or staff turnover, that you really do, and I think the VA has shown this, you really do need a champion, somebody who is designated as a champion to be able to make sure things are moving ahead and that the system is not broken. I also think in the U.S. we need national legislation. Of course, we've been working on that for a long time, unsuccessfully. But, you know, it may come as the costs go up for, at least for us. I mean, we do have the Affordable Care Act now in the United States, which is very exciting. But we still, it's not really being implemented as, you know, as well as it could be. I also think that in home health and home care is where the action's going to be, at least for in the U.S. for the future. And we don't have the resources in place to be able to address those kinds of issues. I don't know if you do. Do you? Do you have those in place?
Oh, I'm working on it. Yeah. So, nope. Hello? Excellent. So maybe I'll just, on that point, I'm Sandra McKay. I'm the manager of research at VHA Home Healthcare, which is a home care provider agency that works directly with patients and their families. And so, you know, this morning I was struck by the number of common challenges between what we experience as a home care provider agency and some of the acute hospitals and the long-term care facilities, particularly those that are a bit older and haven't had the good fortune to move into a new building, but perhaps it's coming. There seems to be a lot of new buildings floating around. But the idea that in theory, what seems to be available versus practically what is available on the units and the wards makes safe moving and handling a challenge that, quite frankly, I wouldn't have been aware of before. And we discussed on multiple times today the particular and unique challenges of providing care in the home, each home that is unique and different, with an independent and autonomous personal support worker who is rushing from visit to visit and needing to be very flexible and creative in the way that they move and handle patients to maintain not only their own safety but the patient's safety. And I think, as Mike was giving his talk this morning, the concept of competence versus compliance came up, and that really struck me because we really have very little leverage when it comes to compliance. They train, we educate, it's ongoing, it's part of orientation, we have buffer sessions, we really consider safe moving and handling to be a shared responsibility. But once they leave, there is no element of compliance. And really what we ought to be delivering is providing them with the skills and the support that they are competent to problem solve with each and different situation that presents repeatedly, day over day over day over week. And it's not 5 sit-to-stands, but it's 5 sit-to-stands in 5 different homes with 5 different individuals and 5 different lighting situations. It's if I allow myself to go down the rabbit hole of all the challenges, we might never come out the other side. But what we really need to focus on is how do we support them and provide them with the tools so that they can make those risk assessments? Because at the end of the day, the risk assessment in the home care field is at the individual level. Given this particular set of circumstances and my particular skills, is this safe? And it becomes a particularly thorny and prickly issue when you then consider issues of power dynamics, fee structures, and how our personal support, and nurses are paid on a per visit basis. And the limited, it was mentioned earlier, the limited right to refuse what is believed to be unsafe work. So there are certainly a lot of significant challenges, but when you have a vision for the long term and how you're going to improve things, and many of the case presentations today, they weren't about 1 or 2 years of data. They started and have information to support since 2005. This is a problem that has been ongoing, and they've been working at diligently for a decade. And VHA Home Health Care is in that same, we're in that process. And for us, that means, given the mobile workforce that we have chosen to partner with our research partners like Tilak and Emily, because we think that those technologies, we can leverage those to help improve our training and education at the individual level so that we can make each person that much better at recognizing and doing their own self-assessment and skills, and teaching them the skills to be vocal and not fall into the trap of the Florence Nightingale syndrome is certainly part of that comprehensive package of safe moving and handling. But we're really excited about the opportunities that present with technology to help us move out of a position where you throw your hands up and say, my goodness, or you wring your hands and say, there's so many things that we can't control. Well, let's focus on the one thing that we can, and that is providing the best support in education and training and tools to support that on an ongoing basis. Yes, those are my thoughts.
Can I just make one point? And that we have in Washington State, we've had, since our legislation was passed, we've had a Safe Patient Handling Steering Committee. And coming from, different hospitals, and we would meet quarterly, and still, all these years later, are still meeting quarterly to talk about what are some of the major problems that we are not able to address, and then what are some ways that we could begin to address them as a group. And having that kind of a steering committee is really like a support group, actually, more than anything else. But it keeps everything alive. And then we haven't taken it to, I think I made my point about, we really haven't done anything useful, in my view, with either nursing homes or home health care, but need to. And figuring out ways to have a community that works around those issues, I think would really lead to sustainability that presently isn't there.
Quiet. Do you want some more comment?
I'm happy to hear some more comments.
The one area that we haven't touched on this slide here is about is in the purple box. And that purple box, for those who are on the table,
mystery slides up here.
is that we have a group of people who are helping to support and transform change within safe patient handling. Some of those are in the field of ergonomics, some of them are occupational health practitioners, some of them might be HR. We have a lot of people who have the ability to collect evidence. And that is we are constantly challenged with people not wanting to support our programs. And so this collection of evidence and the sharing of the evidence that we've seen so well today is a really key part of that. But I'd like to add to the fact that it's not just about the scientific people and about the scientific process. It is about practitioners. And it's about practitioners in their own organisation collecting some evidence and using that to leverage against their policy and process. I mean, if that can also be shared externally, then that is a really positive thing to do. And it feels that, the one or two of us who are part of in the room here who have an opportunity to create research and create some new evidence also have a big part to play in that process. And one or two of the larger groups that I sit with are often challenged with this, with a question that what is the single piece of evidence that we need that will open the doors? Because when you look at medical research or you look at other policy and process and definitions, many of those activities, there is a key activity, study, investigation that just says, that was the thing. We have to answer that thing, whatever that thing is. And I'm always interested at what practitioners think that thing needs to be. I'm sure if we asked the panel and we asked the people in the room, we'd end up with 162 different things that we might need to investigate. But it is, we have collaboration and there is a much more open access to collaborative projects with universities and with government institutions to help collect that evidence and help collect that data. So, I mean, it is a key part of developing the science behind safe patient handling, and hopefully we can just continue to, chip off the lack of evidence and the lack of the success stories as we go forward.
I'd have to say that as the manager of research at a direct service care provider organization, I take it very seriously, my responsibility to elevate the level of science and rigor that exists within the sector, and to share that as broadly as possible, because I think that we all know that opening doors, and more importantly, opening wallets, the key to that is evidence and data that is both rigorous and persuasive. And so what is that seminal piece of data that we need to open doors and wallets still proves elusive. But I do think as an organization, we work with our external research partners, we work with competitors and colleagues in the industry, because at its core, research is meant to create knowledge and information that can change and influence the way things are done. And that's part of our research mandate, is not only to improve the lives of our clients and our families and our providers, but also the sector as a whole, and provide that data to support it.
Thank you. I'm sure you have some questions. So I invite questions and comments from the audience. Here is your opportunity to find out, well, maybe not that thing, but something approaching it. You're not usually a shy group.
Taylor's not shy.
I have a quick question. We've talked a lot about how do you motivate people to change behavior. Are we missing a field of study here that we should think about behavioral economics? Like, is there something about understanding the right ways to motivate people to do things a part of this? I don't know if that's something that people have thoughts on or considered.
Florence Nightingale.
I'm thinking the question sort of almost doesn't have an answer, because it does in a way. It is hard to affect change. And as we all know, we all go on diets, we all do these things, and we're never a lot of times successful, because it is about change, right? So I think you hit a key point, like maybe there is research needed in regards to change, because it's easy to say to a worker, you're going to do this, or there's a consequence. And some of them will still do it, and they don't care about the consequence. Some of them will comply because they don't want that consequence that may occur. But that is a very good question. I don't know that I can answer it, but I do see why we struggle so much in trying to affect change.
I mean, I think that one of the things to add to that is that there is, you go to any academic library, there's there's miles of shelving on change management.
Oh, yeah.
I mean, it's not that we've not that research hasn't been done, but they don't get proper change in their systems either, do they? I mean, it's like, we could go and we could reapply some of that knowledge and some of those processes to some of our scenarios, but it would be an interesting question about whether they would, whether you're storming, norming and performing, or freezing and unfreezing, or any of those models that we've had for 50 years. People have utilised that. They have tried to implement those processes and that learning within their learning and training and education scenarios. But for me, one of the major, it goes back to this complexity question, that we're trying to create change in an ever-changing world. And, what might have worked in, 2012 is not necessarily going to work in 2015. And the organisation that you did it in 2012 is no longer the organisation in 2015. And I do some annual reviews with some of my intervention sites, and I can go 6 months along on a timeline. The managers have changed, the supervisors have changed, and every single staff member has changed also. So, we might have created some change in the people who were there 6 months ago, but it isn't there. The process and the people aren't there. So it is a much, creating change and maintaining change is a challenge in a relatively static organisation, but in the flexibility of what we see in modern healthcare, we can be chasing it for a long time. Ooh.
Can I follow up on that? There are people in the room who say that they have created sustained culture change. What was the tipping point? When did it change from being a few brave champions in your organization to being a culture of safety? I'd love to hear from the people who've had successes here.
Yes, I think the panel is not stepping up, but I don't think it was directed at the panel. I think we'd be happy to take answers from the floor on this one.
I'm going to talk about...
Woodstock Hospital, that was one of the success stories for culture change. Yes.
Woodstock, he said Woodstock.
Woodstock's being the traffic out of town.
Hi, I'm going to kind of not answer any questions and also pose a question. So I guess I want to say, I'd love to stand here and say that Halton Healthcare is an example of one that we have with this, an infectious culture of safety that has, permeated our staff today, our staff yesterday, our staff for tomorrow. And I think that what I will say for that is I think we've got a lot of great foundations. It's a journey that's ever there, and we haven't found the magical solution. So to the point of, there are things that we do that are great, and we have certain cultures, in terms of return to work and lost time prevention, and those things that we can tangibly measure. But embedded in that is a great voice of people who feel that we could do more, right? So when we canvass our staff, and when we canvass our leaders, we do get feedback that says you're not doing enough. So with that said, and the whole concept of, is there something that we're missing here in terms of a motivation, or, what is that key question that we need to ask broadly in all of our organizations, and maybe within the province, within the sector, within the province, within the country, and so on. I think it's, I think we are kind of missing what is that motivational factor that on an individual level, on an organizational level, within healthcare especially, how do we talk about patient care as being a great thing that people attach themselves to and are committed to, and I think that that's a great thing. But I also think, for me, how is that actually defined, right? So we talk about that very loosely. Everyone has an understanding of what that is in their own way, but do we all fully understand how are we measuring what patient care actually translates itself into? Similarly to say, what is that question for safety and for the staff safety? What does that mean, really? And I think we have a lot of loose language that we have legislation, we have policies and procedures, we have individual cultures that we're trying to affect. But I don't know if we've really hit the nail on the head in terms of how to actually make that happen and how to get the attention. So if you were in the private sector, for instance, and maybe there are people here in the private sector, there's a lot of things that speak to revenue generation and the bottom line, and so you have cultures that are built along that, so they equate the lost time of one person to the number of chips that are being manufactured, and that's going to have a reduction on people's paycheck and so on and so forth. But really, we talk about patient care, and that's a motivator for many of our staff that work in healthcare. But do they actually have an impact, like an understanding of what that means, and is it well defined? So that was not an answer to the question that was posed, but I think it's kind of just a few comments as well.
Okay, I'm going to just go a little bit into changing the culture, because in my workplace, we did change the culture. Now, I was, as I say, co-chair for 18 years, and it took 18 years to get there. And Peggy knows that because she was at our workplace at one time before we moved into the new building. You gotta not only talk the talk, you have to walk that. So you have to have the buy-in, and having our CEO sit there, and I mean basically they didn't allude to it, but I made him come to our committee and sit there and listen to what the workers were saying about our health and safety culture. We didn't have a health and safety culture. I was laughing at those slides. We actually had people standing on chairs, on wheels, reaching overhead for heavy things, and then get hurt and say, I don't know how that happened. Like, really, that's what we were doing. We had lifts. We had the millions of dollars of money that came in 2005 for lifts, but nobody was using them. We couldn't find the slings, so hey, it's easier to lift with a draw sheet. We were doing everything wrong. We had to change our culture. So now we have a culture of don't walk by. There is nothing that isn't reported, and I'm proud of that. So we report even near misses. We report everything. And everyone is trained in health and safety. We have safety reps on every unit that do daily inspections, that discuss, as they said, these huddles about issues that may affect the client as well as our staff. But this took 18 years. So this is not something that's going to happen overnight. We're lucky. Our workforce is fairly steady because we are a one hospital town. There's only one hospital. So guess what? We tend to stay there a long time because it's one of the better employers. So at least the higher paid employers. So we tend to keep our workforce for a long, long time. So that's also a very good point, because when you have a hospital, 4 or 5 hospitals, you can shop to wherever you want to go. But in our city, you're staying there. If you want to be a nurse, that's where you're working. So we keep our employees for a long time, and we do things like rewarding them. We have them up on boards. We do all kinds of things to honor the fact that they have a culture of safety in this place, and we make sure our patients and our staff are well looked after, and visitors, everyone. So I have to say it took a long time. It can be done. It's a lot of work. And if those 2 girls that left earlier, they have been the backbone of helping change this. But it's also been everybody's buy-in as well, because if you don't have the buy-in, it's not going to change.
I was just going to, again, try my best to answer Emily's question without actually giving an answer. Hearing from Pam, who's obviously, her facility's obviously gotten there, and then from Ivy, whose program is just sort of underway, like mine, it's in progress. When you ask about sort of that tipping point, that one thing, West Park is going through that process, and I don't really see there ever being one thing that'll shift the balance, that'll shift the culture. For example, our annual back care presentations, sure, they the nurses love them, but what have they learned? So we got to do it again. Why is it mandated that these presentations are done annually? Why is it mandated that orientation happens? Why is there a video? Why is there policy and procedure? Why is policy and procedure written instead of verbally passed on? Obviously for liability reasons, but also I think it's because you have to build it. It's not, you know, hundreds and hundreds of tiny little Lego pieces and then this huge cornerstone that drops and suddenly you are safe. It's hundreds and hundreds of little pieces piled on thousands and thousands of even smaller pieces on top of ground that is molecular to begin with. It doesn't, there's no one piece, there's no one big thing, or at least I haven't found it, and if I do, I will totally tell you what it is. But maybe that's something that Pam can speak to as well. Like, it seems like it's just, it has to grow organically in the system. It can't just find some way where, whoop, yay, we're safe. That would be my thought.
And in answer to that question, there is no one piece. There is no magic wand. There isn't. It is work, and you have to keep, and it always changes. You're always looking at those numbers, those stats. When you sit on joint health, you're looking at these things, and if you see a blip in the radar, and the girls just told me there is a blip in our radar, we just went through massive layoffs again. Guess what? Our incident rates went up again. So these are the types of things, like when you see this, okay, what are we going to do now to address that? What's going to be the actions, recommendations that you'll bring forward? Because these are the types of things that's always changing, and you're never done. I'll never be done this job, I know it, and none of us will be done our jobs if we're passionate about it. We know that there's always change coming, and I think healthcare has to be one of the most complex systems I've ever dealt with.
Hi, Erna Bueno from the Ontario Nurses Association. I just wanted to say we have a lot to learn from the mining industry. I mean, they had so many deaths, and you know, I think about my colleague whose partner worked in the, you know, as a supervisor in the mines, and when he started talking about you know, if workers got injured, you know, management came down on the supervisors. It wasn't right, go to the worker. If you allowed Toronto East is here, but since 2007. And again, it's because that program has worked there, and we have changed that culture there because of the CEO's commitment. Again, just like Pam said, the CEO personally led the charge and sat on that workplace violence committee and, you know, immediately broke off into small groups, and it's been sustainable. You know, lots of people have come and gone, and it's still sustainable. And one of the things that they do is they encourage reporting, not just reporting of accidents, reporting of hazards. And just recently, I mean, just to give you an example of it, imagine when the 2000 incident was actually, or hazard was filed, they walked into the unit with clackers and balloons and a pizza party for the unit whose person reported it. And it wasn't just reporting, because workers there, and you can translate that to MSDs, you can translate that to infection control, any diseases, anything. But if workers see that action is being taken, then they'll be more willing to report the hazards before they become injuries. And so I highly encourage, if you're going to do anything, go back, create your program, and then we also at Toronto East communicated that to people. So they knew what was coming before. So here we're meeting, and everyone kind of went, oh yeah, we're meeting, right? We're meeting, we're going to have a violence program. What does that mean? But they also invested in a whole lot of equipment, and lots of employers here are investing in equipment for, you know, the prevention of MSDs. But report it. So often things are getting purchased and no one knows about it, and no one's going back and saying to workers, okay, we got your input, here's what we did with the input. I think about Windsor Regional, and there's an employer who, Henry, correct me, I think it was 14 indicator project on patient safety that they did, and it was over a 3-year period of time. And they were doing things like you were saying, they you know, put big, I can't remember what she said, big posters in the tunnel, you know, to promote and to acknowledge the staff who were actually making a difference. They gave them a $100 gift certificate after 3, you know, good suggestions and things like that. Always encouraging. When I heard this, I went, this can't be. I actually had to go back to our members and say, is this for real? And they said, yeah, it is actually. And then I met with the CEO and I said, hey, would you be interested in doing something on safety with us? And he said, yeah, actually I would be. It's been a long time coming, we need to. So it's about approaching the CEOs, and I've got to tell you, just from a violence perspective, lately, I'd say what, in the last 4 months or so, Ona's actually been meeting with CEOs, and they're starting to act. So for all of the people that are here and don't have that direct line to your CEO, go talk to them about a collaboration project, if it's MSD, if it's anything else, but figure out how to engage workers and get back to them and show them that you're actually making a difference, and start making the announcements, because you won't change culture if they don't see things happening.
It's almost going home time, so I'll be very quick. I don't expect an answer. I just want to comply with the request for new questions to be answered from practitioners. My name is Jaro. I'm a physiotherapist working for occupational health and safety. Been doing that for 12 years, and I think it's a little bit more complex than just force times arm problem, because we would have fixed it by now. So one of the things that caught my eye was the White Hill project. Anyone familiar with that? At risk of butchering it, I'm gonna summarize it in one sentence. It's basically people who have control over their work don't get sick. People who don't have control over their work get sick, and that's the strongest correlating factor. Money's got nothing to do with it. Other perks have nothing to do with it. Free lunches, barbecues, and so on. So that also sounds to me very similar to the catchword lately, staff engagement, which is chronically low, I think. So that data is already available. If we could pair it up with injury statistics and look for some answers, and maybe get more momentum towards improvement, or at least think about this as a low-hanging fruit, some kind of opportunity, that would be nice. Again, I don't expect an answer right now, but maybe in 5 years, 5 to 10 years, normal funding cycle.
I just wanted to mention that the Ministry of Labor has an engagement strategy currently, and one of the biggest elements of that strategy is about cultivating engagement, getting back to people with what you've done with their information, showing them the success, even if it's that small, even if it's not successful, getting back. That 360 feedback loop. So when you give us evaluation on this conference and you go online at the CRE-MSD website, you'll actually see what other people have said and what you've said and what we're going to do with your feedback. And that's why we're here today. And it sounds like a very simple thing, but a lot of us, I include myself in that, don't always do that 360 feedback and get back to people. And maybe that's a start with engagement.
I had the opportunity a few years back to visit a number of VHA hospitals in the U.S., the Veterans Health Administration hospitals. And I went as part of a project to see what was the difference between those hospitals that seemed to have high injury rates, but were doing the same thing as those with low injury rates. And the HA was really quite perplexed by this. And so I and three other people, we went around to a variety of these hospitals. And one of the things that was the most striking was that the director of nursing services, every single day, and on all 3 shifts, I mean, she was probably killing herself, but anyway, went to each unit in the hospital, basically just to be a support person and to say, what's going on here? Is there anything you need help with? Are we, and just by her presence, that the morale in that particular hospital was totally different, and the injury rates were much lower than the other hospitals that we visited. So I think there's something in that is, I don't know exactly how she was able to do this. If you're a huge hospital and you're going to go to every single unit on all 3 shifts, you've got to be dead, it seems to me. But she was able to do this, and she might not go every single day, but she went a lot. And that's the only hospital that really had a dramatic reduction in their injury rates in the VA system.
Any further comments or questions from the audience? Okay, I'm going to give our panel the opportunity for one last sentence or paragraph or word, if you wish.
By consensus, we think you're ready to go. Consensus is a good word to finish, actually.
Yes.
Participation, agreement, consensus. It's a good way forward.
I agree. Or as our president says, never, never, never give up. Winston Churchill also said that.
Okay, thank you very much, panel.